Regardless of whether you find yourself in internal medicine, emergency medicine, family medicine, or any non-surgical field such as psychiatry, you'll need to know and use basic suturing skills. A simple laceration repair or sewing in an arterial line or a central venous catheter requires the physician to suture and tie quickly and confidently. This presentation, combined with the associated how-to suture video links, will help you gain the skills that you need to complete simple, or with a lot of practice, complex interventions. A separate presentation will be delivered on how to scrub for the operating room and how to gown, glove, and drape a patient to maintain sterility in the sterile field. I hope you enjoy the presentation and the associated videos. And remember, practice makes perfect. At the conclusion of your training, you should be proficient in these different types of surgical hand ties and knots. In addition, familiarity with the various kinds of closures, simple running, locked sutures, simple interrupted, subcuticular sutures, and mattress type sutures. These are the basics that you should know cold before you start your clinical years and enter the operating room. Let me say it again. These are the basics that you should know cold before you walk into an operating room and begin any of your clinical rotations. If your surgeon or your preceptor surgeon observes you struggle in your suture skills, he or she will likely not let you participate in those tasks requiring these skills because, frankly, time is money. Time in the operating room is billed in 15-minute units. The more proficient you are with these skills, the more you'll be allowed to do and see. This isn't see one, do one, teach one. It's about proficiency before you start your clinical training. In the operating room, the emergency room, or a family physician's office, these skills are more important than knowing about sp3 orbital hybridization. We'll want you to identify and describe by name several types of instruments. Just start with the suturing basics. Instruments like the needle driver, forceps, also known as tweezers, but we never ever use that term. So, instruments like a needle driver, forceps, and the various kinds of scissors and sutures are items you should know cold before entering your clinical training or the environment of the operating room. Click on that link above and take the quiz and see how you do with naming the various instruments. There are several types of suture material. Nylon, also known as ethylon, polygalactin or Vicryl, which is absorbable, and other types of sutures will be introduced to you in the operating room. Don't stress about learning all the various kinds of suture material. Here's where you're going to have to trust me. Learn the suture by the trade names, not the scientific names as I teach them here. For example, every surgeon knows what Vicryl is, but not all of them know it's called polygalactin. You'll learn which suture material is permanent, i.e. non-absorbable, those that are absorbable, ribbed, or how many square knots need to be thrown to keep the suture from unraveling. Commit these to memory. Practicing with the different types of suture and trying to get the knot to unravel will teach you too about how many square knots are needed to be thrown to keep the stitch from unraveling. Practice, 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 and then practice some more. The only specialty that I can think of that won't need to know these basic suture skills is psychiatry. And even then, if you have a patient who is a cutter or tries to commit suicide, you might need to patch them up. So maybe not. Maybe all specialties need to know these skills. So after watching the relevant videos, you should be able to also demonstrate proficiency in how to scrub, how to gown yourself and glove yourself, and how to maintain a sterile field and create a sterile field. Let's begin with the instruments. These are Metzenbaum scissors. They're used to cut tissue. A good pair is oiled, maintained, sharpened, and cleaned by the operating room personnel. A new good pair of Metzenbaum scissors is about $250 per pair. The surgical lubricant, called milk, because it looks like milk, is used to keep the instruments functioning well. It's obviously not milk. Never use Metzenbaum scissors to cut suture, paper, or anything except bodily tissues. Iris scissors come in all sizes, long, short, very sharp, not so sharp. They're used to dissect fine, delicate tissues around a nerve, for example. Do not use them to cut suture with. Adson Brown forceps are used to hold subcutaneous tissues during suturing. They shouldn't be used to hold or grab skin edges because the tiny teeth cut into the skin and leave forceps marks. Use these to close the subcutaneous tissues only. When you're suturing skin, you'll want an Adson with teeth, and that's coming up. I'll show you what that looks like. Here's a bandage forceps. Rarely did I use a bandage forceps because by the time the bandage is placed, the operation is usually over and pure sterility isn't usually needed. By the time you're applying bandages, you've broken the sterile field, and the technician is usually helping the surgeon apply the bandages. These Adsons are used to close a skin layer, for example, during a subcutaneous closure. There are many kinds of Adsons with teeth. You just need to decide how large the teeth are and how many teeth are necessary to get the job done with the least amount of trauma to the tissues. In this image, the Adson tissue forceps, you can use these to grab the skin edge. Larger Adsons with teeth, you don't want to grab the skin edge. And as we saw in the previous slide, Adsons with multiple tiny teeth should not be used to hold the skin. Needle drivers also come in a host of sizes, lengths, and sensitivities. Some are up to a foot long or longer. Some are small, 4 inches. And the mouth of the driver is also different depending on if you're sewing with a tiny needle or a large, thick needle. Remember, keep your fingers out of the handles when suturing. Open the needle holder with your palm. Learn to do this for proficiency. This image shows you how you should, in theory, load the needle in a needle driver. If you're left-handed, ask for a left-handed needle driver. It does make a difference. Don't be embarrassed. Note, the needle is loaded at the very distal tip of the needle driver. Here. The needle is grasped at the inflection point. Remember that from calculus in high school or first year of college. And then C, the needle is loaded so that it makes a right angle to the tip of the needle driver. This image shows you everything you need to know about how to load the needle on the needle driver at the very tip, at the inflection point, and where it makes a right angle to the needle driver. The inflection point in math is where a curve goes from curve up to curve down or vice versa. I've highlighted on this slide lidocaine 1% and lidocaine with epinephrine. Lidocaine with epinephrine allows the numbing effect to last longer. Lidocaine and Marcaine are the two most commonly used local anesthetics. They do not work at all in an area of inflammation or pus. Keep this in mind. It's basic chemistry. Most of the local anesthetics are amides, which are organic bases, alkali, whereas material and tissue that is inflamed or has pus is usually acid. So when you inject an organic amide into a field of pus or inflammation, it simply neutralizes the local anesthetic. So if a patient comes in and has a large abscess, please send them to the operating room or get help from an anesthesiologist because local anesthesia is a waste. Now, I've also put here something you need to memorize, the maximum dose of lidocaine. And for a 175-pound adult, that's about 35 cc's of a 1% solution. If you go over this, you run the risk of causing a seizure in the patient. This is a maximum dose of 1% lidocaine for a 175-pound male, about 35 cc's. There are 3 links here. You should start with the last link, the SIM suture. It demonstrates a suture kit and the contents. I really have not found a suture kit worthy of your money. All the kits we recommend you buy from Amazon are not really very good, but they're better than nothing. Then take a look at Dr. Scalpel's guides. He has a nice review of sutures, the sizes of sutures, the needles, how they're packaged. It's a good introduction. And finally, Duke University has placed some surgical videos which are very good at showing you how to sew, how to use suture, how to tie the knots, and how to do the various types of throws and or suture closures. My videos that I've made are similar, but actually I think the Duke videos are probably better. And as you get better in time practicing, you'll want to actually practice your hand ties using something like this, which is kite string, hence the reason the picture for the kite. So what's important here? You need to know what sutures you'll use for different types of tissue, and you'll learn that with experience. Do you need permanent strength, or do you need strength for just a few weeks? Let's walk through each of these. And remember, learn the names and properties by practicing your sewing and knot tying. If you sew with all of these different types, you will easily remember what kind they are, how long they last, and the number of ties it takes to keep them from coming undone. Chromic gut or cat gut used to be made from cat guts, not anymore, but chromic gut is, as it sounds, is somewhat chrome and gray in color. It lasts for about a week, and it is absorbable. Vicryl is absorbable, but it lasts longer than chromic. It lasts for about a month. Dexon, which is Vicryl made by another company, can also last for about a month. These are permanent sutures. Proline, which is fishing wire, Ethylon, which is fishing wire, and silk, just like the silk that's used to make your clothes. These are all permanent. Nylon will last forever, as will proline, and silk will usually last, I won't say forever, but for a really long time. Memorize this chart, and I'm going to show you exactly what it is you need to learn. You need to learn these names under the Ethicon brand. Ethicon is the most common suture maker. Other companies like Braun make their own, and they have different names, but Ethicon is a Johnson & Johnson product, and Tyco or Covidian is the other major supplier of suture. Learn the Ethicon names because you'll never run into anybody who doesn't know these names. So Vicryl is absorbable suture. Monocryl is an absorbable monofilament suture. PDS is a monofilament suture that's absorbable. And here's the days it takes for them to dissolve. You don't need to memorize this. You'll learn this in time. Chromic lasts, like I said, about a week or two. Proline is a permanent suture. It's non-absorbable. Ethibond is non-absorbable. Silk is non-absorbable. Ethylon is nylon. And, of course, steel is used to close the sternum up after heart surgery. So Vicryl, monocryl, PDS, chromic, proline, ethibond, Nurlon, silk, ethylon, and steel. So learn the sutures names by Ethicon, which is Johnson & Johnson company. Learn the properties, whether they're absorbable or permanent, and about how many knots you need to keep the suture from unraveling. Now Gore-Tex isn't mentioned here, but Gore-Tex is made by Gore-Tex. It's in a class all by itself. You must tie about 12 square knots. That means 24 throws. 12 square knots of Gore-Tex, or it will come undone. It will unravel like crazy. Gore-Tex is used mostly in vascular surgical procedures. Now, don't memorize this. You do not need to know these colors, but in time you'll recognize the color of the packaging that goes with each suture type. So you do not need to memorize this, and if you go into psychiatry, you'll never need to know this. But in the operating room, you kind of get used to the colors of these packages. Chromic gut is sort of this color. Proline comes in a blue color. Vicryl comes in a light purple color. Silk, of course, comes in black, and Ethylon, which is a nylon, also comes in black. Don't memorize these. Now in this chart, we're looking at the absorbable sutures, about how long they last, and whether they're a braided suture or a monofilament. This isn't so important. Whether it's braided or mono isn't so important. There's an error on this chart, and I pulled this from the internet. Proline is a permanent suture. It is a monofilament, but it's permanent. It does not absorb. and it shouldn't be on this chart. So first off, buy this type of suture. Click on this link, and it's a stretchy suture. Why do I tell you to use stretchy suture? Because it stretches when your fingers don't. All right. So the bowling ball is here to remind me to tell you, do not put your fingers into the holes of the needle driver. The needle driver is not a bowling ball. This type of string right here should be used when you're first learning to tie your knots. It's stretchy, and then in time your fingers will learn, and the stretch string is no longer needed. But for now, it's really good to learn with and good for me to teach you with. As you get better, go buy some kite string. And then the videos here were created by me to demonstrate the various techniques you should learn now. I actually think the Duke series of videos are better, but watching me tie knots might be more useful than watching another surgeon teach you the skill. So here is how to hold the needle driver. This shows you a one-handed surgical tie. This video shows you a two-handed surgical tie. And this video shows you a subcuticular suture technique. So as a general rule, sutures should not stay in past 10 days. 10 days to 2 weeks. That's usually the limit. If they do, they create these little Frankenstein marks that you can see here in this forehead on this patient. Sutures on the face need to be removed in 3 to 5 days so as to avoid excessive scarring from the sutures themselves. And so the image on the right demonstrates this concept well. You can see the small cross hatches in the forehead scar from the sutures being left in too long. It's also stretched, so this patient has either gained weight or put undue tension on the repair, and it caused the scar to stretch. So look at the finger here. This was closed with silk instead of fine nylon, and the sutures were left in too long, resulting in crosshatch marks on the scar indicated by each of these arrows. Little crosshatch mark there, here, and you can see it here. I'm sure this person has a very unique fingerprint. So now these videos which show you how to scrub before you enter the operating room are very good. In the video on how to gown and glove, when he talks to you, he's not wearing his mask, and that's a mistake. But he does that so he can talk to you. And he also shows a surgeon who at 9 minutes and 30 seconds dries his hands incorrectly. However, normally you will have on your own mask and your own eye protection on. So despite what is shown on television, the surgeon and everybody else puts their own mask on. Circulating nurses do not put your surgical mask on like I've seen so many times in stupid television shows. The nurse does not put your mask on, and she doesn't put your eye protection on. Do it yourself. And if you wear glasses, use the mask that has a layer of plastic film, like a saran wrap like material, and push it onto your face and nose. The plastic layer will keep the moisture that you're breathing out from fogging your glasses. If the operating room doesn't have it, ask one of the nurses to help you. They might have a box for people who just wear glasses. It makes life better for you if your glasses are not fogging up all the time. In this first video, where the urology nurse demonstrates sterile field creation, she does some things that are not quite right. She's not masked, i.e. her breath will carry spit that could contaminate the instruments if she accidentally sputters. And then, of course, in the second video, we have a surgical tech demonstrating how to open a peel pack and some other packages. Also remember how much lidocaine can you use, what's the maximum dose. And she doesn't mention this in the first video, but everything below the level of the table is considered non-sterile. She does say it is waist high. Keep that in mind. Above the table sterile, everything below the table is non-sterile. In the last video, the surgical tech who throws the S-mark bandage vertically so as not to roll, as the towels will stop it from rolling. He's lucky he didn't bounce off the table. When he opens the surgical instruments, he touched it before he plopped it onto the sterile field. Big mistake. The best way is to open and peel open the instrument and then allow the scrub tech who's gowned and gloved sterilely to pick up the instrument and pull it out of the plastic pack. So now let's do some questions to see what you need to know and what's important in this series. So facial sutures should be removed generally in about blank number of days, 3 to 5 days. All these others are too long or you'll get Frankenstein marks. The suture type that's best used where tensile strength is needed for an extended period. So we need tensile strength, extended period. We need a permanent suture. So of those listed here, the only permanent suture is nylon and silk. But silk is not going to be used where you need a lot of tensile strength. You can use it, but it's preferred to use the nylon suture. In theory, this is where a needle should be grasped with a needle holder. Remember the picture? It's grasped at the inflection point. All these other areas are incorrect. Now, every surgeon is a little different. I like to load my needle where the very bottom of the needle is located, at the most inferior point of the needle. But that's just me. Technically, the inflection point is the strongest point to prevent the needle from breaking or from bending if you hold it there properly. So when placing sutures over a vertical knee laceration, the surgeon should use what? Okay, it's over a joint, so we need strength. Strength. PDS is absorbable. Silk isn't. Monocryl is absorbable. Vicryl is absorbable. Ethylon is not. That's nylon. So we've got either nylon or silk. Would you use a running locking suture? No, because if one of the sutures of a running locking suture pulls through the skin, the entire suture is going to become too loose and weak. So you want to use vertical mattress style closure with nylon. This is considered a strength stitch. So nylon and a vertical mattress suture should be used over a knee, and those stitches should stay in place between 10 and 14 days. Maybe longer, but 10 and 14 days you should still be looking at it to make sure that you don't have any infection. Now, you have a guy who weighs 120 pounds. You want to use 1% lidocaine. How many cc's of lidocaine can you use? Go back and do the math, and you'll come up with the fact that it isn't 30, because 30 cc's was about what a 170-pound male had. But if your patient weighs about 120 pounds, if this is a female or a male, doesn't matter, based on your calculations, you're going to use about 25 cc's of 1% lidocaine. Any more than that, and you'll cause a seizure. So here, if we're in the operating room, the belly's open, and you're putting a tie around the short gastric vessels between the stomach and the spleen, it's in a precarious situation. The tie is critical, and you're using silk. You should use a one-handed or a two-handed technique. Well, two-handed technique is safer. It allows you to control the tension better, and it will allow you to place a more secure knot. Okay, so the choice is either going to be B or D. How many knots do we need for silk? We need 3 square knots. So your answer is B. Gore-Tex requires blank square knots for stability, while Vicryl requires how many? So Gore-Tex requires 12 or 24 half throws, 12 square knots to keep it from unraveling. And Vicryl is an absorbable suture that has a tendency to come untied, and it needs about 5 to 7 square knots for stability. So the answer here is A. So now you're on your first surgical rotation as you walk into the operating room table after scrubbing, gowning, and gloving. Circulating nurse says to you, hey, you just contaminated your sleeve. You should do A, look at your sleeve and see if it's indeed dirty. B, assume the nurse is correct and ask her for help to change your gown and gloves. C, because your elbow was contaminated and it's at your side, you continue up to the table since it's out of the plane of the operative field and continue on, ignoring the nurse. D, place a new gown over your existing gown. Or E, remove the gown and gloves, re-scrub, and then re-enter. Well, actually the answer here is assume the nurse is correct. If someone tells you that you have contaminated yourself, there is no argument. You have contaminated yourself. Don't argue, don't question, don't do anything. Just say, okay, let's fix it. I can either put a sterile sleeve over my hand if I accidentally contaminated my elbow, or I can take off my gown and my gloves, and I don't necessarily have to go out and re-scrub. There is a way to remove your gown and your gloves without having to re-scrub. But if you don't know how to do that, ask for help. So in this case, you come into the operating room, it's your first surgical rotation. The nurse says, hey, you contaminated yourself, say thank you, and she'll help you get those gloves off. It's your first day of surgery, and the scrub tech asks you, what size of gloves do you wear? You answer size 7. At this point, you should throw the package on the back sterile table. Just go back and throw the package back there. B, open the package by peeling away the outer packaging and allow the scrub tech to pull the inner sterile packaging out and then glove you. C, tear open the package, open the inner package and proceed to glove yourself. Or D, allow the circulating nurse to get the gloves from the cabinet and allow the nurse to hand them to the scrub tech, who then will gown and glove you. Or open 2 packages of size 7 because you have always been taught that it's safer to double glove. Well, the answer here seems pretty obvious. Allow the circulating nurse to get your gloves from the cabinet in the operating room and allow the nurse to open the peel pack and hand them to the scrub tech. The scrub tech will then help you put your gown and your gloves on. Now, last one here. We got a 23-year-old model. She has a laceration to her forehead. As an eager medical student, you offer to close the laceration using 3/0 silk. Well, if you do that, you're going to leave crosshatches in her in a running locking fashion. 9/0 proline, which is about the size of a human hair, using a subcuticular closure. That might actually work, but proline's a permanent suture, and it's blue in color. And if you use blue in a subcuticular closure, she's going to have a nice, pretty blue scar the rest of her life. You could use 5/0 Vicryl in a subcuticular suture, but that's an absorbable stitch, and it may not hold it. You don't have to sew it at all. You could actually just put steri strips on, and before you put the steri strips on, you put this skin glue on called Mastisol. And you smear the Mastisol on, let it dry, and then you put steri strips on. That would work, or refer the patient to a plastic surgeon. So you're the eager medical student. You got a pretty young catalog model, and she's got a split on her forehead. What do you want to do? Be smart. Refer her to a plastic surgeon. I hope you enjoyed the presentation. If you have any questions, you know how to get a hold of me. And remember, practice makes perfect. Practice the names of the instruments, how to hold them, how to suture, and how to hold that needle driver. Thanks for listening.